All right, so part three, lecture video for chapter 13 in your blue pharmacy practice for technicians. So we left off on slide 18. We're going to pick up on slide 19. So these here are just slides that go through the math that we've already done, calculating milliliters per hour, drug per hour, and then the drip rates. So your vials, so there's different types of vials. So you have single dose vials. These vials do not contain a preservative. So once you open and puncture those vials, they must be used within 6 hours. They cannot be stored in the refrigerator and used the next day, and it's because they do not contain any preservatives. So single dose vials are just that. They're a single use. If you have a larger vial that you're pulling multiple doses out of, you have access to be able to do that for up to 6 hours. Multiple dose vials known as MDVs, so single dose vials are SDVs. Multiple dose vials or MDVs, they do contain a preservative and they are stable for 28 days, typically unless the manufacturer says otherwise. So what you're going to do is there's a beautiful picture on slide 24 that actually shows you the proper way to get into the vial with the needle. So you cannot come directly in. Let me see if I have something to kind of show you here. So if this is my vial here and this is my needle, okay, I cannot come in straight up and down. And the reason for that is because the needle point where the bevel is, which is the pointed tip, if you come in straight up and down in the rubber stopper, it's going to do what we call coring, and that is breaking off a piece of that rubber that will either go inside the vial or it can go into the needle and into the syringe and potentially get into the IV bag. So what you're coming in at a angle, okay? You want to make sure that your needle bevel is pointed up so you can see. Once you clear that opening of the needle, then you can come straight down into the vial. This is something we'll work on when we get to the hands-on portion once we're back on campus. So to withdraw fluid from a vial, you will choose the smallest gauge needle size that is appropriate. You will attach the needle to the syringe. You will draw air into the syringe equal to the amount of drug to be withdrawn. So, I think I have a syringe. Hold on. All right, I only have a 3 milliliter, okay, and this is an oral syringe, but we're gonna pretend there's a needle on here. So with the 3 ml, if I'm drawing out 3 milliliters of solution, before I go into the vial, I'm going to draw back air. So I'm gonna draw back the air to 3 milliliters, and then I'm gonna go into the vial. What this does is when you flip this over and you start adding that air, okay, it's going to equalize the pressure. So it'll be easier for you to get the liquid out. So as you push in and you let go, this is going to automatically push down itself with the fluid coming in. So you're adding air and getting fluid out, so it's equalizing that pressure. Before you inject your needle into that vial, you're going to clean the stopper or the top of the vial. So you're going to swab the top of the vial with a 70% isopropyl alcohol pad or wipe. You will then puncture the rubber top with a bevel up. You'll bring the syringe and needle straight up and penetrate the rubber top. Okay, so once you've penetrated, then we can come straight down. You will invert the vial and depress the plunger, which will empty air into the vial. Again, once you've done that, you can flip it over and you're going to add the air slowly. And as you add that air, you're going to let go of your plunger and it's going to be a back and forth. It's going to allow you to equalize that pressure. You push air in, it's going to draw the solution into your syringe. You will withdraw the necessary volume, so I would withdraw 3 milliliters, okay? You will remove the needle and syringe unit from the vial, and then you will inject into the bag. So if this was my large bag, I would inject into my bag. So withdrawing fluid from a vial, again, continuing. So insert the needle at a 30 or 45 degree angle, then rotate to 90 degrees. Again, this prevents the coring, which is the introduction of the rubber top into the solution. Milk solution by alternately inserting air into the vial and withdrawing solution. So they call that milking, but it's the equalizing of the pressure. We add a little bit of air, we let the fluid come in. Add a little bit more air, let the fluid come in. So we're equalizing that pressure. Tap the sides of the syringe to release the air bubbles. So one good way is to use your knuckle. Okay, this hurts. But using your knuckle it gives it more of a firm tapping to release all of those air bubbles. I don't recommend bouncing this on the surface, and the reason for that is if you are holding a vial up here, you can slip, and I've done this where you slip out, and when you're coming back down, I've had the needle go straight into my thumb. Not a pleasant experience. Reconstituting your powdered medication into vials. So some medication, not all medications come as a liquid in a vial. A lot of times they are a powder, which means we have to add a diluent, which is a liquid, to turn the powder into a liquid solution. Medication may be lyophilized, which means it's a freeze-dried powder. The use of the diluent, such as sterile water or normal saline, typically that's all we use is sterile water or normal saline. Some drugs you can't use normal saline, so then you have to use sterile water, and vice versa. Use a vented needle that allows the diluent to be injected while venting the positive pressure within the vial. That's something that I'll show you as well. So with the vial, you'll take just a plain needle, and you'll puncture that and leave the needle. So it's venting the air out through the additional needle, and you can still go in and draw out that solution. You will check the medication package insert to verify which diluent you're allowed to use and how much or what volume you need to add to that you need to use to add to the vial to make the correct concentration of the solution. So when you let's say you have a vial of a drug that says add 10 mLs of sterile water. Once you do that, you have a concentration of 500 milligrams per 10 ml. Adding the correct amount of solution ensures that you have that correct concentration. When you have that correct concentration, that's how you know how much to withdraw from the vial to get your exact dose. Preparing a CSP with a vial's content. So the vial, a filled syringe, and the base solution are arranged in the hood for the pharmacist to check. The pharmacist will complete the verification. You will swab the injection port on the bag and remove the needle cap from the needle and insert the needle into the port. You will inject the plunger until all of the medication is injected into the IV bag. The technician will remove the needle and syringe unit and dispose of in the sharps container. All of your supplies that you are no longer using, your glass vials, your needles, your syringes, those will always be placed in a sharps container. The CSP, or the compounded sterile product, is then visually checked at that time by yourself. You're looking for things like color changes, any signs of precipitation. Sometimes there can be gelling involved. You're looking for that. If that happens, then it was made incorrectly. Ampules. So ampules are glass. Okay, most of our drugs now come in plastic vials, or they come in glass vials that have the rubber stopper. Some of those, especially in the plastic, certain drugs are not able to be placed in plastic because it either absorbs into the plastic or it eats away at the plastic, depending on what the drug is. So some drugs, not many, but some drugs are still put into ampules. And so you can see what an ampule looks like on slide 30. The neck of the ampule is the critical site. That's where you don't want to be touching with your fingers. You want to clean that and swab it with an alcohol swab with 70% isopropyl alcohol before you break open the vial. Your break ring is a scored area on the neck that marks the site where the ampule should be broken. Okay, so if this was my ampule, okay, I'm going to hold it at top. This would be my break ring area. Okay, and I'm going to hold it at the top, and I'm going to pull the top towards me and push out, and that's going to give it a clean break. We will practice those when we get back, but you'll see that it's, if you push it this way, you have the risk of flinging the glass at yourself. So you want to pull this way towards you while you're pushing with this thumb away. So it's a push and pull, and that'll break the lid off at your break point. Okay. Once you open it, or before you open it, you want to make sure you kind of very gently tap your glass to make sure that all of the liquid that can be contained in the top of it is down. Okay. You don't want to lose any of the fluid by putting that into the top part, because once you break that off, that is discarded. You will wrap a 70% alcohol swab around your neck of your ampule, and that's how you're going to clean it. Okay, using gentle but firm pressure, you will snap the neck of the ampule away from you. So again, we're pulling it kind of towards ourselves here, a pull but a push away from us. Okay. So when you withdraw the medication from the ampule, so you're going to hold the ampule upright, you'll place the needle with the bevel pointing down of a filter needle. So you always have to have a filter needle when you are withdrawing any solution from an ampule. And the reason for that is an ampule, once we break that off, there's little tiny shards of glass that can potentially get inside of the solution. So we want to make sure we use a filter needle that is just going to draw up the solution and leave any of the glass particles behind. We do not want those glass particles going into the IV bag. Tiny glass particles are screened out by the filter needle. Filter needles are unidirectional, so it doesn't matter which way you go in. They can either be used to withdraw the fluid from the ampule or inject it into the IV bag. So I actually teach my students to use two. Use one filter needle to draw out of the ampule, take it off, put a fresh one on, and use a filter needle to inject it into the bag, just as an extra step of precaution. Once you withdraw the medication, you will change the filter needle to a regular needle to inject the contents into the IV. So again, if you use a filter needle to draw it out of the ampule, you can switch to a regular needle to put it into the bag. Okay, if you use a regular needle to pull it out of the ampule, you have to switch to a filter needle to put it into the bag. So a filter needle needs to happen at some point. Again, I teach my students to use it twice, a filter needle to draw it out and a filter needle to put it in, just as an extra set of precautions. So when preparing your CSP with an ampule's content, the ampule, the filled syringe, the used filter needle, and the base solution are arranged in the hood for the pharmacist to verify. So they're going to come in and they're going to verify, yep, she used an ampule, there's her filter needle. Okay, if they don't see a filter needle, they're going to ask you, did you use a filter needle? And then if you're like, I'm not sure, you have to throw the whole thing away. If they don't see a filter needle, they're probably going to have you throw it away too, because they can't ensure that you've used one. The pharmacist will complete the verification check. You will inject the port, you'll remove the cap, and then you'll inject it into the bag. So every place is kind of different. When I worked in the IV room, we were able to do all of the steps, and then at the very end, the pharmacist verified it. We would just draw back our syringe, our empty syringe, to the amount that we put into the bag. So if it called for 3 milliliters, I would pull my syringe back to show them that I did 3 milliliters. But again, every place is different. Some of them want to check before you inject it. Some of you have you injected and just draw back your syringe with air to show the pharmacist how much you put in there. That also depends on how long you've been a pharmacy tech, how long you've done IV compounding. When I first started, the pharmacist would check everything before I injected it, and then after a period of time, they got to know me, I got to know them, they trusted me, and then they would wait to the very end to get everything checked. PPN solutions, again, they only provide short term, so they're designed to be 10 to 14 days, and they only provide part of a patient's nutrition. They're much simpler to do than TPNs, which are total parenteral nutritions. And examples can be just D5W, which is dextrose or sugar, or a fat emulsion. Your total parenteral nutritions are more complex. They have sterile water for hydration. They have dextrose for the calories and energy, which is basically sugar. They have the amino acids for your protein synthesis. They have fatty acids for chemical processes and energy. And then we add things like electrolytes, potassium chloride, potassium phosphate, magnesium sulfate, magnesium phosphate, all of these different elements that we would be getting in our normal diet, but the patients are not because they are not able to eat. Vitamins, we put in different vitamins, multivitamins, B vitamins, folic acid, that vitamin C I've put in there. And then medication, we can also add medication to that. So let's say a patient needs a nightly dose of insulin, we'll put that in there. If they need Pepcid or famotidine because they have stomach ulcers, we can put that in there as well. Your TPNs are at least 1,000 milliliters or 1 liter. In small hospitals, a technician will prepare the base solution. They will draw up the additives and then inject them into the base. In the larger hospitals, an automated compounding device, an ACD, is used. You don't want to have to draw up the TPNs, and luckily here I believe that most of the facilities have the automated compounding device for the TPNs, which makes it so much easier. You will learn how to correctly set the machine to pump the exact amount of each bag. So you can have a bag of amino acids, you'll have a bag of sterile water, you can have a bag of dextrose and a bag of fats, okay, all lined up. All of their tubes are connected to a machine, and you program the machine to tell it how much of each that you're going to pump into an empty bag. If a fat emulsion is ordered as part of the TPN solution, then it is called a 3-in-1. So I do actually, in the pharmacy classroom, when we get back you guys can see it, I do have a bag of what we call lipid fats. It's a lipid solution. It's actually what we give our patients. We got it donated to us, so you can take a look. It looks like milk. It's very milky, but that's something that's added on to the patient. So final check and final physical check and verification. So the technician again will make sure that there's no leaks in the bag, no precipitants, like nothing floating around. Okay. You will lay the compounded sterile product and all of the components out for the pharmacist. That's the only way they can do their final check. The pharmacist will make sure that the correct quantities of the correct ingredients have been added to the bag, and they will make sure that the label is accurate as well. And then they will also check for any precipitants, any floating items in there, and then any visual cloudiness that they can see. All right, so we're going to pause there on that one. If you have any questions, please feel free to give me a call. I'll be happy to help.